morning. Our next plenary is by Professor Aryan Dundop, who is Professor of Tropical Medicine at the University of Oxford. He will speak on new developments in sepsis. Over to you, sir.
Okay, good morning, everybody. Thank you very much for this nice invitation to present here today. So I always like this conference. The breadth of the topics is amazing, and the quality of the speakers also. So we move into highlight a few aspects of sepsis. And it's a very broad topic, so I will just highlight a few things in there that I've listed here. So I'll tell something about developments on the definitions of sepsis, the development of the sepsis guidelines, which have their fifth iteration at the moment, something about antibiotic treatment, and something about fluid management. So how big is the problem of sepsis globally? In fact, we don't really know that. It's not a specific category in the global burden of disease efforts that are published every year by the Lancet. So you sort of have to extract that from other diseases that are associated with sepsis syndromes, like malaria with lower respiratory tract infections, like neonatal sepsis. But the burden is probably huge, and extrapolating from sepsis incidents from resource-rich countries, it's estimated that in low and middle-income countries, around 85% of the burden of sepsis is in low and middle-income countries, which you can see as an extrapolation from the data in the West, because 84% of people live in lower and middle income countries. But that would translate to around 15 million cases of severe sepsis in low and middle income countries, with an estimated mortality of around 20 or 30%. So a huge burden here. We hope these epidemiological intelligence will improve over the coming years, because it's now part of the ICD-11 diagnostic categories, where sepsis is a specific category. So, but to include it in those epidemiological surveys, you have to have a clear definition of sepsis. General awareness of sepsis is not very good, not in the general public. These surveys, they say maybe 10%, 15% of the general population knows what sepsis is. And even among physicians, there's often not a very clear picture what sepsis entails. And that also had to do with a bit of a vague definition of sepsis. It used to be very focused on the systemic inflammatory response to a severe infection. That definition was very, very broad, so it was based on those SIRS criteria. If you would run up and down the stairs for a few times, you almost already met these SIRS criteria. And now the new definition has moved away a bit from that, more focusing on the organ failure associated with severe infections. So the current definition is based on the SOFA score, and you don't need to read that in detail, but here you see the different items, which is a scoring system for organ dysfunction. If there's an increase of 2 or more points in the context of an infection, we call it sepsis. From that, the Q-SOFA, which is sort of a simple version of the SOFA score, has been evolved, which only looks at clinical parameters. So only respiratory rate, altered mentation, and the presence of hypotension has a very strong prognostic significance for death, and also overlaps for 80% with patients identified by the normal SOFA score. So the new definition, the Sepsis 3 definition, is based on the SOFA score and a simplified SOFA score, the Q-SOFA. So this definition, there's a lot of it behind it, because it's not only a prognostic score, but it also says something about the pathogenesis of sepsis. And that's a bit hidden in the definition. So if you look at the causal pathway to death from a severe infection, the sepsis definition says that it is a dysregulated response of the host to the severe infection, leading to all this organ dysfunction, which ultimately can lead to death. So the SOFA score scores the different organ dysfunctions that are here in red, and the scoring they use, the parameters are in purple behind that, and that leads to death. So you can say, does the SOFA score the right organ systems? Well, they're the ones with the best prognostic significance, so then it makes sense. But you can argue if some important organ systems that might be difficult to study at the moment, like a lot of the problems are at the level of the microcirculation, are not part of the SOFA score, only indirectly. But microcirculation is difficult to investigate, so that's why maybe they are not on there. Also, the definition says it's a dysregulated host response. Also, that might not be in general true. So of course there's a pro-inflammatory host response that can lead to hypotension and organ failure. In a lot of cases that will be true. But sometimes there is a much more direct effect of the pathogen on the host, and you cannot always blame the host response for the pathophysiology that comes out of that. An example, for instance, is severe and cerebral malaria, where the infected red blood cells, they sequester en masse in the microcirculation. This is a post-mortal biopsy of the brain, and you see all those parasitized red cells sequestered in the microcirculation, causing tissue hypoperfusion and organ dysfunction. It's not really the host response that is then responsible for the organ dysfunction. And there are many, many other examples of that in the encephalopathy of viral disease like dengue. Dengue directly infects the neurons of the CNS. Or there can be toxins directly affecting organs such as the brain. So the definition still has some culprits, but overall it's a much more workable definition than we had before, with that was based on the SIRS criteria. So using the Q-SOFA score, given the fact that more than 80% of severe sepsis occurs in low and middle income countries, does that score also performs in low and middle income countries? This has been published recently. They retrospectively analyzed eight studies where data were available and looked at the Q-SOFA score compared to the SIRS criteria for sepsis, how well it predicted mortality. And you can see in the lower panel here in the blue bars that indeed Q-SOFA had a very strong prognostic significance for death as an outcome, with a score of 2 or more, which is the sepsis definition, overall having a mortality of around 20%. And a Q-SOFA score of 3, just based on these 3 parameters, so increased respiratory rate, decrease in consciousness, and the presence of hypotension below 100 millimeters mercury, had a very strong prognostic significance with mortality of around 30% if the score was 3. and it performed much better than the old SIRS criteria for sepsis. So the Q-SOFA has very strong prognostic significance, but can also help to identify patients with sepsis, for instance, at the emergency department. So the authors of this article also turn it around, that it's not only a prognosticator, it can also be used for identification of patients with sepsis. By the way, Sri Lanka was part of this big study, which was in over 6,000 patients, over 1,000 came from Sri Lanka. So if we have a better definition, what do we do about sepsis? The Surviving Sepsis campaign guidelines have been very influential for the management of patients with severe sepsis and septic shock. It's now the fifth iteration of those guidelines. It's a big document, around 30 pages. The basic philosophy is that you have to be quick, early intervention, the golden hour, as we know, in ischemic stroke and in myocardial infarction. But if you go through those guidelines, they are very much based on evidence created in rich countries and also tailored for highly equipped ICU settings and Western diseases causing sepsis. So we, with a group of people, went through those guidelines and tried to translate them to low and middle income settings that has been published in open access in the literature, and is now also published as a book, open access book, just seeing what aspects of the Surviving Sepsis campaign guidelines are useful in low and middle income settings and what needs to be adapted. When we did this exercise, we noticed that there's a huge field of research there that we have to go into. A lot of the recommendations, for instance, lung protective mechanical ventilation, probably the most important change in how we care for patients with sepsis and ARDS in the West with low tidal volumes. It's not easy to directly translate that to low and middle income settings. Observations we've made, for instance, in a country like Laos, it's very dangerous to implement low tidal volumes because there's no blood gas monitoring, no capnography, and often these patients are severely underventilated. So a lot needs to be done to translate those guidelines. Similarly, the empirical antibiotic treatment for patients with severe sepsis differs from high-income countries because there are different diseases that are causing sepsis in the tropical world. And I give a few examples. Melioidosis is a soil-dwelling organism causing splenic abscesses, lung abscesses, and sepsis. Some parts of the world, like northeastern Thailand, 30% of all severe sepsis is caused by these bacteria. The empirical treatment is not with the usual antibiotics because you need either ceftazidime or a carbapenem to treat this. So you would miss that with your conventional empirical treatment. Another good example is Orientia tsutsugamushi, or the cause of scrub typhus. Parts of the world, it's also very prevalent in Sri Lanka. Up to 20% of severe infections are caused by this bacteria, and also that is not covered by the usual empiric treatment for sepsis, because you need doxycycline to treat that. So both these diseases are also very important for the Sri Lankan situation, and your groups have published on this quite extensively. And two more examples, severe malaria. Sri Lanka has eliminated falciparum and malaria in general, a huge achievement. You might still see it in your travelers though. Also, of course, requires other treatments with antimalarials rather than antibiotics. And dengue and dengue shock requires different management. But all fulfill the sepsis criteria, so are causes for sepsis. Surveys on the causes of sepsis in low and middle income countries are quite scarce. So a few studies only. If you do those studies, even if you invest a lot in getting the diagnosis, blood culturing all the patients, doing serology in all the patients, a causal etiology is found only in around 50% of your cases. But if you do that, so a lot of the pathogens are very similar to high income settings, but a few stick out. Leptospirosis comes up quite prominently, also in Sri Lanka, a very important disease, of course. And other pathogens that stick out is scrub typhus, as I said before, dengue virus, scrub typhus again, spotted fever group rickettsia. Streptococcus suis is important in Vietnam, comes from the pig farming industry, causing a meningitis usually with a septic syndrome. So causes of sepsis are clearly different in quite a big proportion of your patients in low and middle income countries, and often therefore will require different empirical antibiotic treatment, which can be informed by good epidemiological studies in your settings. Not all hospitals will be placed to have all these diagnostic facilities in place, but can then rely on sentinel sites in the neighborhood of your center. Few words on antibiotic resistance, a huge problem, especially in low and middle income countries. You probably know a lot about this already. ESBL, so expanded spectrum beta-lactamase producing bacteria, gram-negative bacteria. Now over 80% of all the severe infections caused by these organisms are ESBL in India. Numbers are also quite worrying here in Sri Lanka, 60% in China. Other examples of ever-increasing antimicrobial drug resistance, fluoroquinolone resistant Salmonella typhi, very prominently there in India, I think also here in Sri Lanka. And then a very worrying, our sort of last line, antibiotic therapy with the carbapenems. Carbamazepinases are increasingly common. Started in India with the NDM carbamazepinases. The KPC carbamazepinase also increasing. So we are losing our antibiotics quite quickly. Again, for your empirical treatment, this is very important that you know what resistance patterns are there in your hospital, and if you don't have the facilities, that hopefully there's a sentinel site close by where you get a feeling what the antibiotic resistance patterns are. MRSA as a last example also, of course. Very important to know, also very much present in the Sri Lankan situation, mainly in hospital-acquired infections, but also increasingly in community-acquired infections with Staph aureus. By the way, MRSA did not emerge in a developing country, but started in the United States in the 60s. So, because of that, it's important to have your hospital-specific antibiotic guideline based on the most prevalent pathogens in your epidemiological settings. and based on the antimicrobial resistance patterns in your settings. And this is just an example of one of the guidelines we developed together with a hospital in India, and I think it's important for every hospital to have an antibiotic guideline to treat your severe infections. It's important to start quickly with your empirical treatment, which again should be based on your local epidemiology. Every hour that you lose in starting your antibiotic treatment is relates to an increase in case fatality. This study is always quoted by Kumar et al. Canadian retrospective study that saw an increase in case fatality of 12% every hour antibiotic treatment was delayed. The line is almost a bit too smooth to be true, but follow-up studies and also prospective studies have shown that indeed every hour you lose with starting your antibiotic treatment, around 7% increase in case fatality. So the last few slides are on fluid management and vasopressor management of your patient with septic shock. The whole Surviving Sepsis campaign guidelines were very much inspired by this now quite old study by Rivers on early goal-directed therapy of the patient presenting with septic shock in an emergency department in the US. It was quite a small study, 263 patients, but they saw a big reduction in mortality from close to 50% to 30%, using this early goal-directed therapy, which was based on starting fluid bolus therapy early on. That was with the target of a certain CVP, central venous pressure. If the hypertension persisted, then start vasopressive drugs. And if the mixed venous saturation remained low, also start dobutamine or give a blood transfusion if the hematocrit was low. That is still the basic thinking in the Surviving Sepsis campaign guidelines, although a few things have changed. The target is not so much the CVP anymore. Several groups including ours, have shown that CVP in fact is not a very good measure of your intravascular filling status, so we have left that. We look more at fluid responsiveness. We no longer use colloids for fluid resuscitation. The starches have been shown to be renotoxic and be associated with an increase in mortality. So we just use crystalloids now. Most centers just use normal saline. These balanced fluids are becoming very popular in Western settings, are much more expensive. No real good studies yet showing their superiority over good old normal saline at the moment. And we also don't use this mixed venous oxygen saturation anymore, which depends on a Schwann-Ganz catheter or similar catheters. In fact, we have moved away from the Schwann-Ganz catheters because they are very expensive, are not associated with improved outcome. But still, the philosophy of this original River study is very much there in the Surviving Sepsis campaign guidelines, which is early fluid bolus resuscitation. They recommend a bolus of 30 mils per kilogram patient as sort of the minimum. If then hypertension persists, start your vasopressive drug, noradrenaline as the first choice there. And if there are remaining signs of hyperperfusion where your plasma lactate is the most convenient measure, if you don't have that, you have to more rely on the clinical signs like skin mottling, reduced urine output, and things like that. Then also start dobutamine. However, giving fluid bolus therapy has a risk, of course, to contribute to pulmonary edema. Not only ARDS, ARDS is also not fluid dependent, but will be aggravated by fluid bolus therapy. So that is really the downside of giving fluid bolus therapy, especially in settings where there's not easy access to positive pressure mechanical ventilation. By the way, it's not only fluid resuscitation in the initial phase that might have to be a bit more restricted, especially in settings lacking mechanical ventilation, but maybe more in general. But also de-resuscitation is important. Get the fluids out as soon as the patient is stable. When I started ICU care 20 years ago, we used to give a lot of fluids, as you see in this patient there. It has now been clearly shown that if you are more restricted in the later phases, the time on mechanical ventilation is importantly shorter. But about the initial fluid resuscitation, so for the tropical setting, that might not be the right approach. And there are several studies to show that. This is the so-called FEAST trial in children in African settings. A lot of those children have severe malaria as their cause of sepsis. Their mortality was around 30% higher in the group that received fluid bolus therapy, either with a crystalloid or albumin. So this general recommendation of giving fluid bolus therapy in sepsis is not the right one for this setting. These were African children, but also in adults. This is a study from Zambia. Adult patients presenting with septic shock, and they compared the Surviving Sepsis Campaign guidelines with fluid bolus therapy with the local standard, which was much more restrictive in fluid management. By the way, 90% of those patients were HIV infected with low CD4 counts, so it's a bit of a special group. They did not have easy access to mechanical ventilation. As you can see, following the Surviving Sepsis Campaign guidelines in that setting, quite importantly, increased mortality instead of saving the patients. But also in Western settings, if you compare the early goal-directed therapy with normal standards of care, they have not been able to show a survival benefit of following this approach. 3 very large studies, one from the UK, one from the US, and one from Australia and New Zealand. None of them have shown a clear benefit. There's a lot of discussion whether then we should leave the Surviving Sepsis Campaign guidelines. I don't think we should, but it does show once your general level of care has improved a lot and mortality is already down to 20-30% compared to the 50% mortality in the original RIVER study. It's difficult to lower mortality further. Second thing is it's a hugely heterogeneous group, patients with septic shock. Pathogens are different, host responses are different. That also probably plays a role. And a general problem with these studies testing a bundle of things. So the early goal-directed therapy has like 10 different interventions that are tested at the same time. If you don't see a difference, it's very difficult to tease out which aspect of that bundle was not good for those patients, and other aspects of that bundle might have been beneficial. But overall, these results have been a bit discouraging, of course. Something we are looking at the moment is how we can use lung ultrasound for guidance of fluid therapy. Nowadays, very cheap bedside ultrasound machines, and they're very good at picking up pulmonary edema at a very early stage. You see these B lines appearing on the lung ultrasound. We're currently evaluating if that might be a good tool for monitoring fluid therapy in patients with severe sepsis and septic shock. So, in conclusion, the definition of sepsis has moved away from the SIRS criteria and are now based on the organ dysfunction score, where this Q-SOFA is a easy bedside test that has strong prognostic significance and can also easily identify patients with sepsis. The Surviving Sepsis Campaign guidelines, it's great that they are there, but they are quite specific for resource-rich settings. They need translation to the more resource-restricted settings. There's now an adapted version for low and middle-income countries. Empirical antibiotic treatment for your patients with sepsis is very important, and again might differ a lot in your local setting compared to the very general recommendation for empirical treatment. And fluid therapy, fluid bolus therapy, be careful if you give that to your patients if you don't have access to a mechanical ventilator. Thank you very much for your attention.
Thank you very much, Professor Dando. It's a very important and very timely lecture. Unfortunately, I know the audience may be having a lot of questions, but time is limited. So I think you can meet Professor Dando during the tea time, so you can ask questions. On behalf of Sri Lanka Society of Internal Medicine, I would like to invite Professor Tilak Weeraratne to deliver certificate of appreciation.